Welcome, everyone. My name is Jamie. I'm with the Cancer Prevention Control Program at the University of Colorado Cancer Center. And we're really excited to offer the next iteration of our CPC monthly seminar series. And today, our guest is Dr. Bethany Kwan from the Department of Family Medicine at the University of Colorado School of Medicine. Bethany is someone who has been doing a tremendous amount of behavioral science work here through the Department of Family Medicine, is affiliated with the Accord Center, and also leads or does work with the Center for Clinical and Translational Science. She got her bachelor's degree from Carnegie Mellon in the very interesting combination of psychology and chemistry. Haven't seen that one before, Bethany. And then a master's in public health from here, Colorado, and then so a PhD in social health psychology from the up north in Boulder. And Bethany's done a tremendous amount of work and has had a portfolio of funding in implementation science and health services research. And a lot of it has been in diabetes and some other health behaviors. But we're really excited that she has turned her attention a little bit to cancer, and in this case, particularly her work in brain tumors, and applying what she has generated in her knowledge of fund of knowledge with regard to stakeholder engagement, patient engagement, and using that, leveraging those skills and applying them to the brain tumor environment. And I will let Dr. Kwan say anything more about that, but I think it's also a wonderful example of how bringing tools and being somewhat opportunistic and drawn in by some passions that may not have been anticipated, but nonetheless brought forth a tremendous opportunity in terms of engaging with individuals who are experiencing brain tumors. So I'll turn it over to Bethany and let you run with it.
Thank you very much, Jamie. So just a quick overview of my talk today. So I will start with just a little bit of background on the burden of brain tumors. Then I will describe two different projects and efforts that I've been engaged in over the last about 5 years around stakeholder engagement in brain tumor research. First, as part of the Brain Cancer Quality of Life Collaborative, and then with a brand new National Cancer Institute funded U2C Center grant, optimizing participant engagement in molecular characterization of low-grade glioma, which we call OPTIMA. And then if there's time, I'll spend a little bit of time talking about stakeholder engagement method selection and introducing a tool that we've developed in Accords and through the data science to patient value group to help guide the process of stakeholder engagement method selection and application. So a little bit on brain tumors. The average 5-year survival rate is only about 36% across all different types of brain tumors. The lowest 5-year survival is glioblastoma, which is up slightly from the 70s, which it was at 4%. Now it's at about 7% for 5-year survival. We've really just seen modest increases in survival since the 1970s and very little change in treatment. There's just a tremendous opportunity to learn and continue to grow new treatments and addressing the many different sequelae resulting from brain tumors. We also see there's quite a bit of racial disparities and geographic disparities in survival rates, and these are also a priority for us. Importantly, brain tumors are associated with physical, psychosocial, and spiritual challenges that affect quality of life. There's really a wide variety of different quality of life concerns that people with brain tumors have, from physical to cognitive disabilities, a lot of distress and anxiety and personality and behavior challenges that are of particular concern to family members and care partners. There's also a lot of financial stress and healthcare navigation challenges. So one of the things that we've explored in our research is the opportunities for building palliative care. That is a form of specialized interprofessional care that focuses on improving quality of life of patients and care partners facing these multidimensional challenges associated with serious illness and brain tumors in particular. And it's known that offering palliative care at the point of diagnosis of a serious illness with standard of care for treatment may improve quality of life, symptom management, decrease invasive interventions at the end of life, and potentially improve overall survival. However, palliative care is underused in brain tumor contexts, and there is no evidence-based model of palliative care for people with brain tumors. And so I want to tell a personal story before I get into the research that I've done. So on September 4th of 2015, I was homesick and I received a phone call from my stepfather saying my mother had had a seizure at work. And so we raced to the hospital. Thank goodness we all lived in Denver. My brother and sister and I all lived in Denver. And unfortunately, over the course of the next few days, it became clear that she had a rather large brain tumor and she required surgery very quickly. So she went through surgery, she went through the standard treatment. Turned out that it was in fact a glioblastoma. As I mentioned, only that 7% 5-year survival rate, average survival being really closer to about 1 year. And it was really a very difficult treatment process. We had some palliative care referrals, but she really didn't want it. My mother was a physician, she was an OBGYN, and still she just really didn't feel like engaging with palliative care. And she passed away on October 1st of 2016. On October 13th of 2016, you'll notice 5 years ago today, I decided that it was a good idea to go to a conference. And the picture you see in the lower right-hand corner is the library at UC San Diego. It's the only picture I have of that day. And that day was very important because that was the day that I met Liz Salmi, who ended up being my brain tumor patient partner in all of my research activities. You'll see lots of Liz throughout this talk. We decided after we met that brain cancer sucks and that we should write a grant to study how to address quality of life concerns in people with brain tumors. And so we wrote a grant to PCORI a contract, a proposal to PCORI to develop a stakeholder group to study brain tumors and quality of life for people and care partners experiencing the effects of brain tumors. That grant was funded 1 year to the day that my mother passed away on October 1st, 2017. There was a lot of work we did in the meantime. I'll tell you about that in a minute. And then just a few weeks ago on September 21st, 2021, we received a notice of award for our NCI Center grant. And then here I am today presenting to you on our experience. So you can see there's a lot of meaningful dates in September and October around this work. And just briefly, here's Liz. And Liz and Shirley Otis Green, who's a palliative care social worker, we were the ones who wrote that initial proposal to PCORI together. And one of the things that we said outright was we really need to gather multi-stakeholder perspectives on the experience of quality of life and the need for palliative care for people with brain tumors. And so I want to give a little bit of background on what we mean by stakeholder engagement. So stakeholder engagement refers to a bidirectional, longitudinal relationship between stakeholders and researchers that informs decision-making about research prioritization, its conduct, and dissemination. So importantly, it's about the relationship. And importantly, it's about prioritization, conduct, and dissemination. It's not a one-time thing. It's not just going in and getting information, such as through interviews or focus groups, but really about working together over time throughout the entire process of research. Ideally, stakeholder engagement will consider the perspectives of multiple stakeholder types. We use the 7 Ps model of stakeholder engagement, considering patients, care partners, healthcare providers, advocacy groups, policymakers, as well as researchers, to ensure the research is feasible, scientifically rigorous, and relevant to answering real-world questions. I already mentioned this is a common framework that we use for multi-stakeholder perspectives in stakeholder engaged research. You can see these different stakeholder types listed here. There are a variety of different approaches and frameworks that you can use to guide the process of stakeholder engagement, but some core principles include, again, the importance of reciprocal relationships and sharing decision-making and authority in conducting research. A lot of co-learning. So we are not the only experts. The patients, the care partners, the clinicians that we engage, they are experts in their own domains. And it's important that we learn from and respect each other's expertise and what we bring to the table. Partnerships are critically important, really valuing the time and contributions of our stakeholders that are coming to the table, paying them, making sure that they are recognized for their work. And then ultimately, transparency, honesty, and trust, as you would expect, being core principles of relationships in general. So everything we do, all decisions we make are shared readily with all of our research partners, and we're committed to open and honest communication with each other throughout this process. I really like this International Association of Public Participation, or the IAP2 spectrum of public participation, to help think about the various ways and contexts in which we can engage stakeholders, varying from sort of very minimal impact of stakeholders on decision-making within a particular project, just informing the public, all the way up through fully empowering and placing final decision-making in the hands of your stakeholders that you're engaging. I tend to work a lot within the involve and collaborate areas. Full-scale community-based participatory research often does fully empower communities to make final decisions. So as I mentioned, our very first project was this PCORI-funded Pipeline to Proposal Award that we called Optimizing Palliative Care for Patients with Brain Cancer and Their Families. This was launched in 2017, and Liz Salmi, my patient partner, was the lead, the primary lead on this project, and I was her co-lead, backing her up. Our mission was to engage diverse stakeholders who care for people with brain cancer in the prioritization, design, and conduct of research that supports quality of life for patients and their care partners. And ultimately, our goal was to identify, test, and disseminate models of healthcare and palliative care in particular that would support quality of life. And you can see our website here if you want to go read more. So in the context of this Brain Cancer Quality of Life Collaborative Project, we used multiple methods for engaging multiple types of stakeholders. We really thought stakeholder panels are great for getting a lot of in-depth input, but maybe it wasn't comprehensive enough for getting broad perspectives on what we really needed to learn about research priorities and co-design and conduct. So we did establish our Brain Cancer Quality of Life Collaborative Stakeholder Panel. And then we engaged a group called the SHOP to facilitate a design thinking event. And then, because Liz and all of her friends are very active in the brain tumor social media space, which if you follow on Twitter, they use the hashtag BTSM to follow along. They have a monthly chat, the hashtag BTSM chat, that you can use to follow there. And we did a series of what were called tweet chats with that community. And then we also engaged through the Society for Neuro-Oncology and started a special interest group around palliative care for brain tumors. So lots of different ways that we engage different types of stakeholders in understanding quality of life needs and opportunities for research in palliative care for brain tumors. So we first convened the Brain Cancer Quality of Life Collaborative virtually, and you can see upper left-hand corner, I think this was our very first kickoff meeting, and you can see Liz on the larger screen on the top of the slide here. And this was the very first time most of us had been in communication synchronously. A lot of them had been friends and communicating asynchronously on Twitter for many years, and they graciously brought me into their fold. And you can see here, Michael Fratkin and Adam Hayden, along with Liz, are very well-known brain cancer advocates. Dr. Fratkin is a palliative care physician, does a lot of rural palliative care work. And you can see here this quote from Adam, that the subjective viewpoint a patient brings to bear on the understanding of illness and disease provides a robust, rich, and informative source of information. And so Adam and Liz and Michael have been really critical stakeholders as we develop the research and think about how to reach the communities that most need to contribute to the work that we're doing. And you can see we started with 16 founding members of the BCQLC, representing a wide range of different types of stakeholder perspectives. As I mentioned, building stakeholder relationships was really important. And so this was in February of 2018. We were able to gather together in Sacramento for a design thinking event, all getting together in person. This is in fact the only time we have ever been in person, the only time that I have ever been in the same room with Liz. And so this was just a really critical way for us all to develop that close relationship and partnership moving forward. Beyond that, we did meet regularly, mostly through Zoom. So as I mentioned, this design thinking event, which is a common methodology in user-centered design for brainstorming different ideas for how to accomplish or to overcome a particular challenge. And our design challenge at our design thinking event was, how might we learn how to best deliver palliative care for brain cancer patients and their care partners? And what we did throughout this day with facilitated support from the shop was come up with these key research priorities. Number one being, we really want to study early palliative care for people with brain tumors, building upon seminal work from Jennifer Temmel on early palliative care for lung cancer. We also heard a lot about the need for care partner support, and certainly I was a loud voice there about how important that was. There was also a lot of talk about the need for policy change around payment and insurance coverage for palliative care. A lot of concerns about communication and doing research around how to distinguish appropriately between palliative care and hospice. Certainly, if we want to do early palliative care for people with brain tumors and their care partners, we need to know, well, what is the model of palliative care for people with brain tumors? We ultimately figured out that that form of palliative care is maybe even more similar to other sorts of neurological conditions, Parkinson's disease, than it is for other types of cancer. So we said we really need to understand quality of life needs for people with brain cancer so we can design a palliative care model for brain cancer. And we spent a lot of time talking about, well, what's the secret sauce of palliative care for brain cancer? As I mentioned, we held tweet chats. So these are like focus groups on Twitter. And so they advertise these, they're held for about an hour, and they pose 4 questions, 4 topics, once every about 15 minutes. And they use these hashtags to gather together and make people aware that this is happening. And we have about 40 people who participated in each of 2 chats, one with the brain tumor social media and one with the hospice and palliative medicine social media community. And what we were able to do is download the transcripts from the chat using a tool called Simpler, and then perform a qualitative content analysis. And so we have a paper that was published in, I believe, the Neuro-Oncology Practice, in which we report multiple themes around quality of life needs and palliative care opportunities for people with brain tumors. And you can see a couple here. One of the main themes being that the quality of life for people with brain tumors has many dimensions. There's just so many different concerns, and they can change over time. We also heard that there really is a need to better address quality of life in the context of healthcare, including in decision-making about treatment and support for care partners. I believe we have the citation in this talk. And so if you wanted to read more about what we learned and the methods that we used to do a qualitative analysis around tweet chats, you can look that up. And then we spent a lot of time after that doing research co-design and thinking about this palliative care model, building on what we learned from our stakeholders and from our tweet chats, and ultimately came up with this proposed model around a personalized approach, or maybe a precision approach to palliative care for brain tumors, with 4 elements. One being identifying the patient and care partner identified concerns. What are the needs? What sort of services and approaches are best geared towards addressing those needs? How will those needs be fulfilled? And then element 3, by whom? Who are the members of the interprofessional care team that are available to help address those needs and fulfill those services? And element 4 is the importance of when, this notion of delicate timing. The needs and concerns among those with brain tumors can ebb and flow over time. And so we really think that it's important to consider kind of the sensitive timing, that delicate timing around when these services are offered and how and by whom. And then we've done a lot of research dissemination, multiple conference posters and papers. And what you'll see is Liz has been, if not the lead author, then a really primary author in many of them, as have many others of our stakeholders that have been engaged throughout this process, including Adam and Shirley Otis Green and Lynn Taylor, who's a neuro-oncologist. And so one of the very first things we did is test out this qualitative content analysis of tweet chats. So we took a tweet chat that had been conducted before we got involved, downloaded the transcripts and did the qualitative content analysis around advanced care planning perspectives and brain tumor stakeholders. And then here's our neuro-oncology practice paper on stakeholder engagement in research on quality of life and palliative care. This is our qualitative analysis of the brain tumor social media and hospice and palliative medicine tweet chats that we planned and conducted ourselves. We did tell the participants that we would be using this to inform research, and we did ask for permission to include any direct quotes. As a result of Liz's primacy in Twitter, in social media around the brain tumor space, she's pretty well known. And we heard from Dr. Elizabeth Klaus at Yale University. She reached out to Liz to say, would you collaborate on a project? We would like some help recruiting for our low-grade glioma registry. And by the way, I would love to do some stakeholder engagement. And Liz said, well, let me introduce you to my friend, Bethany, and we can help you. And so what I will show you in just a moment is a result of a couple of years of working together to try to get funded around this Optimum project that I mentioned earlier. So Dr. Elizabeth Klaus runs the low-grade glioma registry at Yale University, and as a result of this work has been able to contribute to genomic research in brain tumors. Dr. Klaus is a neurosurgeon and a PhD biostatistician, and I just feel really grateful that she reached out and thought that we would have something to contribute to the work that she's been doing. So she had come across this participant engagement in cancer genome sequencing, or PECGS network, that was currently seeking applications. And these U2C research centers have 4 components. They have an administrative core, and then usually center grants have like 3 R01s. And so the 3 R01 type projects within these U2C research center grants are, number 1, the participant engagement unit. This is the unit that actually goes out and tries to recruit people to participate in the research. There's a genomic characterization unit. This is where the genomes and the characterizations happen. It's not my area of expertise, despite my bachelor's in chemistry. And then importantly, the engagement optimization unit, which is what we're leading here at the University of Colorado for this project. So we were finally funded. It took a round of revisions, but we were finally funded as the Optimum project. And this is a collaboration between Yale University, University of Colorado, and the Jackson Laboratory for Genomic Medicine, which is based in Hartford, Connecticut. And the 3 principal investigators are Dr. Klaus, myself, and Rolver Hawk. And so the overarching purpose for Optimum for the center is needing to do comprehensive genomic characterization of lower grade glioma and the molecular evolution. So importantly, looking at how the molecular and genomic components of these tumors change over time. And so in almost all gliomas, what ends up happening is that you can treat the initial tumor, but then it inevitably comes back. And so that recurrence is something that's not particularly well understood. So a big part of these mechanisms is to really understand how we go about understanding, how we go about gathering enough people to participate. Often these are pretty rare diseases, relatively speaking, and getting enough specimens so that we can understand that process of change over time. And then ideally, that means that we can start to understand different types of treatment for different types of genomic characteristics of these different tumors. And that's the extent of my understanding of that part. Where I come in is that in order to get enough people to participate in this study, we know that we really need to do community and stakeholder engagement to build trust, to build relationships, so that people feel comfortable not only contributing their health data, but actually their biological specimens to this registry. So we know that Optimum will be the first large scale and patient engaged effort to provide a comprehensive genomic characterization of the evolution of primary low-grade gliomas through recurrence. Overarching specific aims, we of course have these 3 units as required by the network, engagement optimization, participant engagement, and longitudinal genomic characterization. So how do we actually go about encouraging broad, diverse participation in research on lower grade gliomas? So we know that reach and representativeness of participants in lower grade glioma genomic research is heavily oriented towards more white people that live in more urban areas in particular, and that receive care through academic cancer centers. We also know that trust, ethical values, and willingness to participate in genomic research are related. So the challenge that we sought to address through our engagement optimization unit is figuring out how do we operationalize ethical values such as autonomy, privacy, ownership, relevance. How do we operationalize those in the context of recruiting patients to participate in research and engaging them in the process of research? And the hope is that by operationalizing these ethical values and demonstrating that we are trustworthy, that we will build trust among the public in the type of research that's being done here, and also enhance the relevance of perceived research. So if people are involved in coming up with the research to begin with, potentially they see greater relevance and are more likely to see benefits of participation. The hope is that by building trust and perceived benefits, that we will increase broad representative participation in research, which ultimately is needed for rigorous, reproducible, generalizable science, as well as addressing concerns about health equity. Another consideration is that the science of stakeholder engagement is largely in its infancy. We don't know a lot about the efficacy of different stakeholder engagement methods. They haven't been empirically studied very often. There's really very little evidence base around which works well under what circumstances. There's also a very limited evidence base on comparative effectiveness of engagement methods, and we don't have any information at all around determinants of appropriate stakeholder engagement methods. So this project was the opportunity to both better engage the brain tumor community in participating in research and to answer some questions around how to conduct stakeholder engagement well. Thus, the purpose of our engagement optimization unit is to fill these gaps in evidence, both around stakeholder engagement and optimizing the methodology being used for stakeholder engagement, as well as to actually promote participant engagement in the registry, including recruitment, data sharing, and return of results. Our research questions are: to what extent and in what ways do stakeholder experiences and perspectives on ethical conduct of low-grade glioma genomic research differ among stakeholder panels and social media engagement methods? You might recall this was something that we did in our Brain Cancer Quality of Life Collaborative, but didn't actually directly compare them. And then to what extent do messages and message tailoring approaches informed by the elaboration likelihood model, which is a common model of communication and information processing, affect trust and willingness to participate in the low-grade glioma registry? And then finally, to what extent do user-centered designed messages, materials, and protocols for participant data use and privacy education, data sharing, and return of results enhance trust and satisfaction of registry participants? Our engagement optimization unit team is primarily comprised of investigators from the University of Colorado, and also includes Liz Salmi, and as well as Liz's mentor, Dr. Kate DeRoche, who is at Beth Israel Deaconess Medical Center and the director of Open Notes. Liz also happens to be the research communication specialist with Open Notes. She is multi-talented. So one of the things that they require within these PECGS awards is demonstrating integration amongst all of the different units. So our engagement optimization unit, aim 1 is optimizing stakeholder engagement. Aim 2 is optimizing registry participant engagement. And the idea here is that we will work in concert with the participant engagement unit and the genomic characterization unit to make sure that what the stakeholders are proposing is both relevant and feasible from a scientific perspective and from an IRB perspective. And that we will, after we've optimized these different components, we will turn them over to the PEU and the GCU to implement and do large-scale testing of effectiveness of our optimized approaches. We're using what's called the multi-phase optimization strategy as an overarching framework for the process of optimization. And so what you'll see here is that the 4 main steps in the MOST approach is the preparation phase. So doing some initial work around stakeholder engagement and preparing to develop the messages and materials. Then we'll do some optimization using user-centered design to develop message content and packaging. Then we'll evaluate, we'll test these optimized recruitment messages in a SMART study, so a sequential multiple assignment randomized trial. And then when we're satisfied, our stakeholders are satisfied, we'll release these optimized strategies to the participant engagement unit. And we'll repeat this approach for things like return of results templates with the GCU, as well as whatever other things our stakeholders indicate they would like us to optimize for registry participation. We will have a stakeholder advisory panel, and the overarching goals of the stakeholder advisory panel are to inform and operationalize the ethics framework, to design and test the participant recruitment materials and messages, to design and test educational materials and return of results templates and procedures, including involvement of genetic counselors, and then finally to interpret and disseminate findings from the Optimum project and prioritize future research using the registry. Our stakeholder advisory panel will be led by 3 patient community leaders, and you can see on the right here. So Charlie Blattner, Liz Salmi, and Neslin Gay are the 3 patient community leaders that have agreed to be leaders of the 3 different types of engagement methods that we'll be using. Liz will lead the stakeholder advisory panel. Charlie will lead the Twitter community, and Neslin is the administrator for this oligodendroglioma, low-grade glioma warriors Facebook group that she started that has thousands of members from worldwide. And you can see here, Charlie has nearly 3,000 followers on Twitter, and Liz has nearly 7,000 followers on Twitter. So these are very, very well-connected people. Our stakeholder advisory panel will also have other low-grade glioma registry participants, care partners, clinicians, a genetic counselor, regulatory and data governance experts, advocacy organization representatives, such as from the National Brain Tumor Society, as well as a representative from the Genomic Characterization Unit, so that we make sure that what we're proposing is really feasible and can be implemented within their laboratory. So what exactly will our multi-stakeholder advisory panel do? So we plan to have we originally planned to have a full day in-person meeting. That will not happen now. And that's really our initial opportunity to build stakeholder relationships, as I showed with the Brain Cancer Quality of Life Collaborative. It'll be interesting to see how that works when we can't get together in person. We will hold monthly web conferences with the advisory panel to think about how we are going to operationalize that ethics framework and inform design of recruitment messages and informed consent. In years 2 to 3, we'll have at least quarterly web conferences. We'll certainly leave it up to the advisory panel how often they want to meet. Often, in my experience, they don't like quarterly. They feel too disconnected, and so prefer at least monthly meetings. We'll see what they want to do when we get together. I am hoping that 3 years from now, we will in fact be able to meet for a full day in person to reflect upon all the work that we've done together, look at the results of what we've learned, and start to prioritize research using the registry and as a team moving forward. Comparative effectiveness of engagement methods, of course, is our aim 1. And so I thought I would lay out here the 3 different methods, our advisory panel, a Facebook chat, as well as more tweet chats on Twitter. We've noticed the Facebook community can be really different from Twitter communities. So there's a lot of different perspectives and communities represented on the different social media platforms. And so our goal is to compare using mixed methods, advisory panel, as well as Facebook and Twitter stakeholder engagement methods. And the different features of these engagement methods include the different types of participants, the number of participants, the location and the platform, the leaders of each group, the duration and frequency, the format of engagement, and the data sources that we'll be using to evaluate them. In the optimization and evaluation phases of the MOST framework, we have planned to do a SMART design study. to test different types of recruitment messages and materials. And as I mentioned, the elaboration likelihood model is the model we're using to develop our different messages and materials. And so there's, within that particular framework, you can develop messages that are either what's called high cognition value, like lots of in-depth information to help people make very informed decisions about whether they want to get involved in the registry, versus what's called a low cognition value message. So just a very simple, straightforward call to action. Please join our registry. And so we would really like to understand, there's very little evidence on the comparative effectiveness of these two different types of cognition value messages for recruitment for clinical trials and clinical research in general. And so we'll be learning a lot about the order and the sequence and the types of characteristics of potential participants and who responds best to which types of messages. So, as I mentioned, Optimum is recruiting people who have had recurrent low-grade gliomas. And because Liz is such a committed researcher, she has decided to go deep undercover, and I was unfortunately diagnosed with a recurrence about 12 years after her first experience with brain tumors. And the danger of getting involved in brain tumor research and in cancer research in general with stakeholder partners is now you're friends with people who have brain tumors. And so we were very sad to hear that Liz will be having brain surgery again, but she's really making the most of it and using the opportunity to learn about what it's really like as a patient to help to contribute to the low-grade glioma registry as a patient with a recurrent tumor. She's already learned so much about trying to access her data, to communicate about how her specimens should be preserved so they could be transferred from California to Yale or to the Jackson Laboratory. And so we're very grateful for her deep undercover work and commitment to being a true patient stakeholder in our research. So in my last 10 minutes, I promised that I would tell you about, well, what if you wanted to go about doing stakeholder engagement in your research? So the Data Science to Patient Value Initiative, or D2V, which was one of the Dean's transformational initiatives funded probably about 5 or 6 years ago now, has a dissemination, implementation, communication, and engagement, or DICE work group. And our group, or the DICE work groups, our goal was to answer really two critical questions. So number one, how might we help researchers select appropriate engagement methods? And also to determine to what extent might an online interactive web tool support uptake and use of stakeholder engagement methods and enhance our capacity for consultation on these methods. So we developed the Stakeholder Engagement Navigator, which you can find at dicemethods.org. And the Stakeholder Engagement Navigator is designed with health researchers in mind. That's really our primary audience. And it's intended for use by researchers at all career levels, at any stage of a research project, from planning through implementation to dissemination. And even those with lots of experience in doing stakeholder engagement can find this to be a really useful tool for narrowing down the many options for stakeholder engagement methods. I use it myself all the time. So this tool provides both information about various methods for engaging different types of stakeholders in research via the Engagement Methods Education Hub, and also has a selection tool to pick strategies based on specific engagement purposes and constraints. So here's the homepage. There's a little video. If you want to hear more from me about what stakeholder engagement is, you can go watch our video. And then you'll see we do have the Education Hub and this engagement method selection tool. If you want to jump straight to understanding the different types of methods that are available, we have these strategy fact sheets that give you a synopsis of each method, approach, or tool used in stakeholder engagement, so that you can download it and use it to guide your work. The stakeholder engagement selection tool encourages you to think through 5 key domains before using the tool. The first is, what is your purpose? What do you hope to achieve through stakeholder engagement? The second is, what's your budget? Do you have any money at all? Do you have millions of dollars to spend on your stakeholder engagement? How many times do you expect to be able to meet with your stakeholders? Some types of stakeholders, they really are only available one time. You might get 20 minutes with them. And then over what period of time, how many interactions and how much time per interaction do you anticipate you might have available for your different stakeholders? And then finally, what types of staffing or expertise are available to you? Which are you really able to do feasibly? So we focused really on selection of stakeholder engagement methods based on purpose and feasibility. There are many different stakeholder engagement methods out there. There's a number of them listed here, ranging from appreciative inquiry to community engagement studios to human-centered design. And of course, stakeholder advisory panels and committees are common as well. And our website has definitions and guidance on each of these. The selection web tool, after you've chosen your research stage and your purpose of engagement, there's these slider tools to help you narrow down the options for appropriate methods that fit your purpose and your research stage based on your budget and your expected number of interactions and time per interactions with your different stakeholder types. And you see that the larger little bubbles here, the darker bubbles, are those that are best match for what you've indicated as being your purpose and constraints. So feel free to take a look at the dicemethods.org website, and thank you for your time today. If you would like to reach out, here's my contact information. Me and my 564 Twitter followers would welcome you joining us. Thank you.
Thanks, Bethany. It was terrific. And like I mentioned, I'm really glad that you told your story about your personal connection to it, because I do think, you know, we in the oncology community are benefiting from your telling that story and translating what you've learned from your engagement work into the oncology setting. And there's just a tremendous amount of opportunities. While others prepare their questions, I have a couple that I'd like to pose to you. And the first one is, how'd you get connected with Maya Reblin? I noticed her show up on your publication, so I assume it's more than a passing connection. But perhaps more importantly, could you say a little bit more about the how you've worked and why you chose the elaboration likelihood model, and what was compelling enough to you about that model to have it drive some of the design features that you were wanting to test?
Yeah, so great question. So when we did our design thinking event in Sacramento in February of 2018, one of the main things that rose to the top of that conversation around research priorities was communicating effectively about the distinction between palliative care and hospice, and also addressing the needs of care partners. And through our various connections that we had, we were looking around for someone who might be an investigator who would dig into that research priority, who might we partner with, that's an expert in that area. And Maya, who's at, she's since moved on, but was at the Moffitt Cancer Center in Florida at the time, emerged as someone who would be an expert in that area. And so we reached out to Maya and asked her to join the Brain Cancer Quality of Life Collaborative as an investigator. And so she is now, she's has like
Vermont.
a leadership, sorry, what was that?
Isn't she in Vermont?
I believe that's correct. And has like a leadership training position through the Society of Behavioral Medicine. So that's really been a very fruitful partnership for both of us. And then you asked about the elaboration likelihood model. So we have a health communication expert on our team, Dr. Jenna Reno. And when we sat down to think about how we were going to design the messages and materials and address what we know about some of the main challenges in people with brain tumors, is the cognitive impairment that can come along with having a chunk of your brain removed. And so that was Jenna's recommendation, that there's opportunities to use that elaboration likelihood model to test different strategies and different types and degrees of information provided when recruiting people to participate in research. So does that answer your question?
Yes, yeah, very much so. So thanks for that. Evelyn has a question.
Yes. Okay, so racial and ethnic disparities, we know that the survival rate for people who are Black and Hispanic are in particular substantially higher or substantially lower than people who are white. And I believe the data that I saw most recently was for the lower grade gliomas, it's like an 86% 5-year survival rate for people who are white and 76% 5-year survival for people who are Black. And so the factors underlying those racial disparities in 5-year survival for brain tumors, we anticipate are due to access to care and access to early identification and treatment opportunities. There's just a lot of work that needs to be done around better understanding that and addressing those concerns. And then any cancer disparities incorporated in the Optimum study. So absolutely, yes. We had actually written another R01 that was not funded to do some design and engagement in specific communities. So in particular, Hispanic and rural communities, to really dig into how do we help recruit for participation among those communities in particular. We're hoping to write a supplement or resubmit that R01 so we can layer on to what we're doing in Optimum. And then in the current Optimum study, we do have plans to, number one, track over time the demographics of those participating and making sure that we have geographic diversity, racial and ethnic diversity, as well as gender diversity in participation in the registry. And we will adjust and respond to those data and prioritize our efforts in communities that are needed to enhance diversity and participation. And we have explicit research questions for the overall Optimum to evaluate whether our increased engagement is addressing differences and disparities in participation in genomic research.
Great, thank you for that. Because we need more representation in registries and biobanks to be able to address questions. Is there a reason why survival, besides access, which we know, right?
Right.
Differences, across ethnic groups. So
right.
I applaud you for doing that.
Yeah, it's very important.
So I have a question, if that's okay. Sure. Can I jump in? I'm changing the topic. Is that okay?
Yes.
Okay. Okay. All right. First of all, thank you for that talk. Very nice work, and really fulfilling clearly a gap that was there that people weren't addressing. So really fantastic. Congratulations, and congratulations on the PECGS funding. I actually wanted to ask you about the PECGS, and you just mentioned, as you were answering Evelyn's question, about how you would change things, as you went along. So it looked to me that the way so this is really a logistics question. I'm just curious. So the way that the PECGS was set up, you're the optimization unit, and it sounds like you're the front loader, right? You guys are the ones that are really, really super operational at the beginning, right? Mm-hmm. Then you turn it over to the engagement unit. Do I have this right? And then they recruit people, and then once they're recruited, then the genomics happen. So it's almost like this sequential thing. But you just implied with Evelyn, and this was really my question, are you going to continue to engage your stakeholders, and how are you going to make this dynamic? How are you going to, because when you want to figure out response rates and all this other kind of stuff, and you have specific questions that you want to answer too based on your specific aims, it just seems to me that there's a tension here between what has to happen sequentially and what is dynamic. So I just wanted you to comment on that.
Oh, that's such a good question, Linda. It is rather interesting so we say, well, give us a year, we'll tell you, how to recruit. Give us another year and we'll tell you how to get the data. And the overall lead and the genomic characterization unit are like, but we can't wait. And so what ended up happening is they said, oh, sure, yeah, go over there and optimize stuff, but we're gonna jump in. And their approach is, Liz, what should we do? and so our baseline, our control group is, what would Liz Salmi do? Is what we're calling our baseline comparison. It's a rather interesting notion to say our comparative effectiveness actually has a fourth arm. And it's, if you find one really well connected, really well engaged patient partner who's been through this, how far do they get you in accomplishing your goals relative to, well, we're going to add in 15 more people's perspective, and then we're going to add in hundreds and thousands of more people's perspective. What do you learn as you consistently layer on more and more people? So that's one thing, is we do need to get started. They're not waiting for us. They're going to go. And Liz says, well, we can just start with making your website prettier. You can get pretty far with a pretty website and a better YouTube channel. And then absolutely, yes, this multi-phase optimization strategy where we're optimizing something and then releasing it is a little bit aspirational. I don't necessarily anticipate that we're going to perfectly optimize through our optimization strategies. I do think that we will learn and continue to need to adapt over time. I don't think this will be one and done sort of thing. It will be ongoing.
One other question, Bethany, you probably saw this as well, but I heard for the first time a few weeks ago the term engagement science. And I wanted to get your thoughts on, is this really a new science, to its own, or what? And are there any seminal work using that terminology that we should all know about?
Very little. We're trying to make it one. Trying to make it a science. You might be referring to PCORI's request for information around the science of engagement. Have you seen that RFI from PCORI? They're planning on issuing some funding opportunities related to actually studying the science of engagement. There really is very little empirical evidence and no comparative effectiveness evidence, as I indicated. But there have been calls in the literature to better study and understand this. So the work that we've been doing with DICE is pretty groundbreaking in that regard, not something that a lot of people have been doing. So we are very much looking forward to this study, this Optimum project being one of the very first planned comparative effectiveness methods in stakeholder engagement. But even then, it's not randomized. And it would be very, very difficult to have a large enough set of stakeholder groups, community groups, projects with enough variability that you could randomly assign to different stakeholder engagement methods. You really need an enormous population and a lot of resources to do that well. So we think that there are opportunities to study stakeholder engagement methods, but a lot of challenges and barriers to doing so. As in all sort of dissemination implementation science, that it takes large samples to do it well.
Yeah, and I think your work has really championed the stakeholder engagement in terms of at least patients at this time. One of the things that we're working with in terms of facilitating translation is clinician engagement with novel information and figuring out ways. And Erin and I have already taken a look at DICE methods and starting and added a layer onto how we're conceptualizing our efforts to get build engagement with clinicians about something that's new on their radar, in terms of integrating that and the challenges to that, community translation.
Absolutely. There are so many different stakeholder perspectives, and if you really are anticipating a large population level change in how care is delivered and how care is paid for, and for whom care is given, it will take many layers of stakeholder engagement and testing of patient level strategies, community level strategies, and system and policy level strategies.
So it sounds like you think this will develop into a legitimate science of itself, and I did see that call, but I also saw it used in the context of some things that the NCI implementation science group was calling out, and I think there's an upcoming symposium or seminar that bridges those two concepts of how they connect with each other. So. Any other questions or comments from the group before we let Bethany get back to work launching our new grant?
I just want to say I really support having an engagement science. I really do. And it's like implementation science. Like, why did we wait so long to, actually get to implementation science, right? So I think it's a great idea. So go for it, Bethany.
We will. Everyone needs to contribute.
Very good. Well, Bethany, thank you very much. Congratulations on your work. We're looking to find ways. I appreciate the outreach you've done with us to engage you in the Cancer Center, and we are looking ways to support you and collaborate with you. I know, Evelyn, as the Associate Director for Community Outreach and Engagement, has been percolating ideas and was thrilled to hear of your funding and ways that we can really champion it and support it. So thank you very much.
Thank you.
Okay, bye everyone. We'll see you next month, if not sooner.
Bye.
Bye.
Bye.